Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Well, hello. You're in for a treat today. Today, our show is rapid response. Now, what is rapid response? When I used to work in a hospital setting, obviously rapid response was not really good news because it meant that one of the patients that was at the time in a hospital system needed additional medical attention. So all of us, physicians and nurses, we would stop what we're doing, we'll drop everything, and we'll run as fast as we could to help that patient and their medical team to actually do the best they can to bring the patient back to a stable condition. And so rapid response in my mind is one of those situations where you drop everything you're doing and kind of reroute yourself to really benefit a patient and to help your medical teammates to achieve a good result. So once in a while, patients would ask me a question, and it sort of triggers a rapid response for me because I would then say, well, do I really know a good answer to this question? It's something that is so important, so transformative if we do know an answer that we have to drop everything and just run and get the answers and hopefully give our patients an opportunity to live healthier lives and to take ownership of their health and to modify what they're doing so that their health is transformed. So this week, rapid response comes from a question asked by one of my patients. And the question that he asked is, Doc, how much weight do I need to lose in order to improve my blood pressure? Now, this is sort of a simple question, and a lot of patients and a lot of individuals ask this question of themselves every single day. This is probably the most common question that gets asked. And unfortunately, in traditional medical encounters, there's sort of a generic advice, lose weight, exercise, eat right. In the holistic medical encounters, especially holistic cardiology encounters, we're all about figuring out how much weight you're supposed to lose and how you should exercise and what you're supposed to eat and what supplements you're supposed to use, if any, and where is the room for medications in this entire lifestyle approach, right? But this question honestly consists of two parts, because what this patient is actually asking, Doc, how much effort should I keep on putting into this in order for my blood pressure to show meaningful change? And what is meaningful change? And many patients also, on the back of their mind and maybe even on the front of their mind, are aiming to reduce or come off blood pressure medications. So the second part of this question is that, what should I be doing and how much weight should I be losing for me to be able to reduce or come off blood pressure medications? And this second part, reducing or actually controlling blood pressure without medications, is known as a remission. Now, you have probably heard of a remission from more chronic and life-threatening diseases, cancer, for example, right? Someone could say, well, my cancer is in remission, which means that I don't have any signs of it, any evidence of it, and it had been treated and it's currently gone. But blood pressure or hypertension is actually also a chronic disease that bears a significant cardiac risk. And so do we have any information on not just controlling or improving blood pressure, but actually putting it in remission so that a person has optimal blood pressure without the use of medications. And so it intrigued me, this question, and it triggered my rapid response because there is sort of a generic answer to this. And then there is an answer to this, which is more specific. And I do believe that each and every one of you should be able to know the answer to this question. And if you're asking yourself what you should be doing to control your blood pressure or potentially to go in remission, hopefully this episode will provide you with some clarity into what direction you should be going. Recently, European Society of Cardiology has released an update on the elevated blood pressure and hypertension diagnosis and management. It just happened in August of this year. The American College of Cardiology, which is the organization for cardiologists here in the United States, and some of our international colleagues had released their guidelines in 2017, and so far there's been no revision of those guidelines. Now, this is very interesting between obviously 2017 predated coronavirus pandemic and 2024 post-dated coronavirus pandemic. So there are a lot of intricacies in the European Society of Cardiology guidelines that actually reflect the experience of physicians and patients during the times of the pandemic and the shift in how we approach evaluation in this brand new era of telemedicine and digital devices. Hi, everyone. It's Dr. Regina here. I know there are contradictory opinions about nutrition for heart health and longevity. Discussion often gets heated and confusing. There are those who push for low fat, low cholesterol, and then there are fans of a ketogenic diet. There are many anti-meat voices as well, suggesting vegan or vegetarian style of eating. With all the chatter out there on what and how to eat, my team and I decided to create a tool for patients, medical professionals to clear the clutter. It is called Holistic Heart University, and it provides on-demand courses, nutrition and lifestyle resources, information on supplements to make it easier to understand how to make healthy choices for your heart. I'm especially proud of our open office hours for program patients and the Q&A feature where you get to ask your individual questions and put us in the hot seat. Head out to the show notes for the link and use my special promo code to get a huge 20% off on our annual health and wellness subscription. The code is owner20, and I'll see you in the office hours. But I wanted to share with you what I would like for you to know so that you can take ownership of your blood pressure and you could actually own your heart health and improve it in a meaningful way. And it starts with us asking a question that a patient asked me, how much weight do you need to lose to lower blood pressure? Now, notice I'm not saying to remit your blood pressure to achieve control without medication. Let's just go first into the lowering of blood pressure and see how much of it we can actually manipulate through weight loss and what kind of weight loss you potentially may be needing. Now, blood pressure is a complex subject, and this is only the beginning of our discussion of blood pressure. We will, of course, be discussing it quite often throughout some of these episodes. And I invite you to, in addition to rapid response, log in and listen to the Gallery Gadgets episode where we'll be going over measurements. And this is my blood pressure gadget in here. But for now, let's just go with the basics. So the American College of Cardiology has a category table for blood pressures. And you could see here that blood pressure is considered normal when it's less than 120 and less than 80. The 120 mmHg stands for millimeters of mercury, refers to systolic blood pressure. So you see it abbreviated as SBP. And the less than 80 refers to a diastolic blood pressure, which stands for DBP. Now, people often refer to it as my upper number and my lower number, my top number and my bottom number. But in the sense, there are always two blood pressure numbers because the blood pressure in our vascular system is never zero. If it's zero, then we really are in pretty bad shape. So the 2017 guidelines from American College of Cardiology are indicating what we should think about blood pressure. Now, this is not based on someone taking a single measure and just saying this is what my number is. No, this is actually based on at least an average of a couple of careful readings. And again, in the Gadget Gallery episodes, we will talk about how you should properly measure your blood pressure and what blood pressure cuffs you should be using and how you should be looking at these numbers carefully to make sure that you get reliable information, right? But in all of the estimates, we're assuming that an individual had the chance to measure their blood pressure in stable conditions. It was carefully measured. They were at rest. They were using appropriate equipment. And these categories, blood pressure categories, are actually averages of what was determined at least a couple of times, if not more. And typically in clinical practice, I ask my patients to record blood pressures for a couple of weeks, morning and night. And, we look, of course, at these averages as well as other patterns that blood pressure recordings could let us know. When in the American guidelines, the normal blood pressure is less than 120, less than 80. Once the blood pressure crosses the threshold, so it let's say it measures 120, but it's still less than 80, we are going to call it elevated blood pressure. And you could see that elevated blood pressure has a fairly narrow range. There's about 10 millimeters of mercury in a systolic blood pressure. And once it crosses into 80, equals to 80 or more on your lower number, your diastolic blood pressure, one would then be assigned as stage 1 hypertension. So the American guidelines are very granular. Less than 120 and less than 80 is normal. Once a person goes over 120 to 129, blood pressure is considered to be elevated. If the upper numbers are behaving themselves, but this lower number, diastolic blood pressure, is 80 or more, this is already considered to be hypertension. And hypertension is divided into 2 stages. Stage 1, which is your upper number systolic blood pressure between 130 to 139, or your diastolic blood pressure is 80 to 89. Notice the switch between and or. And stage 2 hypertension is when your upper number is 140 millimeters of mercury or greater, and your bottom number is 90 millimeters of mercury or greater. Again, it's not both, it's or, right? So stage 1 could be called even in somebody whose systolic blood pressure is not at stage 1 level, because their diastolic blood pressure meets stage 1 criteria. And the same is for stage 2. Now, you may say, okay, well, this is good, but what about the situation where I measure blood pressure at home? And actually measuring of blood pressure at home, the home blood pressure monitoring, is a very popular and very common technique. And a lot of the times we advise a patient to measure blood pressure at home, because we know that when they're in the clinic, when they're in the office setting, things may be provoking anxiety, and it's noisy, and maybe they're aggravated, and maybe they ran to their appointment. There could be a lot of mitigating factors, and just seeing them in the office is one moment in time, while at home they actually have an opportunity to measure multiple times and to make sure that they're relaxed and their arm is well positioned and that they are not intimidated necessarily or aggravated by the medical office or hospital setting. So the home blood pressure measurement in the American College of Cardiology tables, you could see it here. It's abbreviated as HBPM, which literally stands for home blood pressure measurement. And of course, there are prescription-based alternatives such as ambulatory blood pressure monitors, and that's ABPM. Often they run for 24 hours. But the important thing to notice here is that between the office blood pressure and the home blood pressure, there should be a fairly strong relationship. So for 120 over 80 in the clinic should still be 120 over 80 at home on average, unless a person has white coat hypertension or masked hypertension. And those are very specific conditions that, allow or make us see the discrepancies in the blood pressures. And you could see that 130/80 kind of follows the same pattern. And once blood pressures start to get a little bit on the higher side, this is where we expect that the home blood pressure may actually be lower, because we are potentially seeing a bit of an exaggerated response in the clinic setting. Now, using these criteria, one may ask, how commonly would I actually see this? Is it expected that as an adult in a certain age group, I may actually become a hypertensive? And you could see that overall, in terms of the crude numbers, hypertension or elevated blood pressure, unfortunately, is actually quite prevalent, right? So if we're looking at the thresholds of 130/80 or reported use of hypertensive medications, it's about 46%, so almost half of the adult population. And if we're looking at the thresholds of 140/90 or reported use of medications, it's a little bit less, about a third of the adult population. And certainly looking at this table, you will notice that the prevalence of hypertension varies by ethnicity, and it also varies by age group. And as individuals age, the prevalence of hypertension increases, whether you're looking at 130/80 threshold or you're looking at 140/90 threshold. You could see that in their 50s, and this is actually an eye-opener for many, in patients or individuals who are in their 50s, anywhere from 50 to 70% will actually be in that greater than or equal to 130/80 group, or using medications in that group. And obviously this number becomes majority of individuals once they cross into their mid-60s and even in their mid-70s. But instead of this doom and gloom, let's pivot a little bit to the newer era. And in the newer era, the European Society of Cardiology has actually given us a very nice and robust and clinically useful approach to blood pressure. Instead of dividing it into these, 130/80, 140/90, stage 1, stage 2, they said, look, let's consolidate these measurements. Let's make them practical. Let's make them reflect what patients are actually seeing and reporting back to us and what we see in the clinic, right? And so they have designated blood pressure measured in office or at home, which is less than 120/70, as non-elevated blood pressure, right? So if you are in this less than 120/70 category, remember it's the average readings, right? It's the mean, then you're really in great shape. Now, once an individual crosses into this 120/70 domain and all the way up to 140/90, but not equaling 140/90, this is elevated blood pressure. And you could see that there could be a bunch of different readings here, because the home blood pressure could actually be somewhat lower. The ambulatory blood pressure monitors tend to be even lower than that. The office blood pressure could be a little bit higher. So this is the elevated blood pressure zone. Now, it's important that elevated blood pressure zone gets noticed and gets monitored, and a person starts on a path of lifestyle modification, because this is where we have the greatest chance of reversibility, right? This is just the beginning of the arterial hypertension that could be influenced by lifestyle modification a great deal. Hi, everyone. It's Dr. Regina here. Many of my colleagues and I are noticing patients coming to us with self-ordered blood tests. When this trend started to gain momentum, I thought it would benefit many patients. After all, who doesn't want more access to health testing? However, I see that self-ordered labs often lead to more confusion and frustration for our patients. Patients are coming in with a pile of labs, and sadly, they're not better off for it. This is why we at Holistic Heart Centers have launched Heartwell Toolkits, a curated collection of blood and genetic markers that one can get at home, focused on heart and brain health, gives you all the data you need to make informed and actionable health decisions. The toolkits can be ordered at our shop on holisticheartcenters.com. You can find the link in the show notes. use the code testing10 to get 10% off and free shipping. And of course, once the blood pressure becomes 140/90 or greater, the European colleagues are not really dividing it into, stage 1 or stage 2. They basically just call it hypertension. And you could see that the home blood pressure has to be somewhat lower, but not tremendously so, by about 5 millimeters, right? So once that home blood pressure on average is 135/85, this is actually hypertension. So I do like these newer guidelines from the European Society of Cardiology a little bit more. And if you're listening to this show or watching it on YouTube, you will actually see these slides. But, it's easy enough to remember. If you're less than 120/70, you're great. If you are at 140/90 or more, you are not great, because that's consistent with hypertension, and everything in the middle is the elevated blood pressure. And so a young patient asked me, who already done a lot of work, and this patient lost 10 pounds. And the patient asked me, okay, well, how much more, or what is the measurement stick? At what point will my blood pressure end up being normal and will actually go into remission so that I will not need medications for blood pressure? And so I said to myself, there are a lot of interesting information in the literature about this, but when I look through the entire European Society of Cardiology guideline or the American College of Cardiology guideline, they didn't really give a specific measurement stick. What they said is that, sure, reduction in body weight is very beneficial, and to get some blood pressure reduction, you need to reduce your body weight by anywhere from 5 to 10%. Well, this patient lost 10 pounds. So does that even matter? And so what I discovered is that, as the rule of thumb, based on the research that was done, 1 kilogram reduction in weight usually decreases systolic blood pressure, so that's your upper number, by about 1 millimeter on average. This research was published in 2001, and if you are not on the metric system, but on the imperial system, the one that we use in the United States, that's 2.2 pounds. So for my patient who dropped 10 pounds, that at best would equal somewhere to 3 and maybe to 5 millimeter reduction in their blood pressure. So if they started, let's say, from blood pressure of 150, that could potentially take them to 145, but you could see that this is still in the hypertension zone, right? Now, this particular research in 2001 was for something called Trials of Hypertension Prevention. It was a fairly large study. It had almost 2,300, almost 2,400 men and women. They all had this high normal blood pressure, and so they were divided into 2 groups. One group received lifestyle modification with the intention to lower their dietary sodium, really achieve weight reduction. And the other group was just the usual care group. And they were followed for 3 to 4 years. And it became apparent that for them to sustain blood pressure reduction, they had to maintain at least close to 5 pounds of blood pressure, of weight reduction, for at least 6 months. Otherwise, it would reverse itself. And this is where the researchers were able to come out with that formula and relate the amount of weight loss to the approximate reduction in blood pressure. So for each of the 2.2 pounds of weight lost, a 1 millimeter of mercury from the systolic blood pressure reduction was expected. Now, in 2014, there was a different study, which was actually a study that emphasized looking at the percent weight loss, not just the raw pounds, but the percent weight loss from baseline. And this study is what's called a meta-analysis, because they have included data from multiple other studies. Some of these studies were observational, so they just followed people over time. Other studies were what's so-called randomized controlled clinical trials. And then came to the conclusion that 5 to 10% reduction in total body weight will actually reduce blood pressure. And again, we're talking about primarily that systolic blood pressure, that upper number, by 5 to 10 millimeters of mercury, especially in those individuals who are obese to begin with. And what was interesting there is that this didn't really change with age or gender or even baseline blood pressure. That's what they observed. And their reasoning was that the reason why we're sort of sticking with the same number is that reduction in this total body weight leads to clinically meaningful blood pressure drops and improvements in lipid profile and reduction in insulin resistance. So there was a cardiometabolic effect that actually led blood pressure reduction, right? And it pointed to a comprehensive strategy where diet, exercise, behavioral interventions really need to be dialed in for this to happen. But you know, as well as I do, that not all weight loss is created equal. Right? We assume that most of the weight loss is actually fat loss, but in some situations, the fat loss also comes with the muscle loss. And we had recently seen a lot of literature with regard to GLP-1 inhibitors, medications like Ozempic, Wegovy, Zepbound, where we know that significant weight loss is not just fat loss, but muscle loss as well. And so investigations point out that this relationship of 1% reduction in body weight to approximately 1 millimeter reduction from the systolic blood pressure is actually mostly driven by the loss in visceral fat. So the studies have shown us that 5 to 10% reduction in body fat, specifically visceral fat, the one which is in the organs and in between the organs, is what drives this relationship between weight loss and blood pressure reduction. Now, this makes sense because we know that fat loss actually reduces our inflammation situation, right? Fat loss reduces pro-inflammatory cytokines, which are internal components secreted by our fat. It decreases insulin resistance, and it both improves our vascular tone and reduces peripheral resistance. Because remember that the heart has to pump and perfuse all of the tissues in the body, and the heavier the body is, the more resistance there is to it, because there is just a fairly significant amount of tissues that the heart that ejects the blood out has to reach even the most tiniest of blood vessels and the capillaries. And the more those there are, the harder is heart's job. And so this loss of visceral fat significantly improves vascular function and actually leads to reduction not just in this systolic blood pressure, but to a certain degree of the diastolic blood pressure as well. Now, a lot of these studies were small studies. They included maybe just 40 patients, 90 patients. They were very short term. They didn't last beyond 12 weeks, but they provided good estimates because they measured body composition. And in earlier trials, the body composition actually was not measured and certainly wasn't consistent. And so the fat-specific interventions, the interventions that allow us to normalize the cardiometabolic environment, to promote metabolic flexibility, that reduce that visceral fat, is what actually drives the blood pressure reduction. Well, you may say then, well, what about the muscle, right? What about the muscle gain? If I'm losing fat, shouldn't I be gaining muscle as well? We know about the role of resistance training and how impactful it is. Turns out that there isn't such a nice relationship between the gain of the muscle and the blood pressure reduction. Although in studies, it's been noted that resistance training alone can lower blood pressure by 3 to 4 millimeters, systolic and diastolic, even though significant fat loss may not have occurred. And there was an interesting study in 2013. Again, it was a meta-analysis, and it showed that particular fact, that the resistance training alone without fat loss can actually lower blood pressure by approximately 3 to 4 millimeters. A little bit, usually it's 3 to 4 for systolic and 3 millimeters for diastolic. And that is attributable to the fact that muscle is a metabolic sink, right? It allows us to deposit glucose in glycogen form. It actually contributes to muscle mass, contributes to maintenance or increase in the metabolic rate, and it reduces insulin resistance. And so there are quite significant opportunities there. When you build muscle efficiency, you will end up with better vascular function. And it was an interesting study because it kind of pulled together all these disparate little studies that were going around. It was another meta-analysis. There were a total of 93 studies that were included. They were all randomized controlled clinical trials, and they had body composition measurements. There were about 5,000 participants altogether. And that's what was essentially determined, that when there's aerobic exercise together with resistance exercise, and there is fat loss that may or may not be significant, but the resistance training allows us to build muscle, we are able to achieve these small blood pressure reductions. However, there wasn't such a relationship between muscle building or muscle mass as we have with fat loss. Fat loss, definitely the correspondence between each percent of fat loss and a reduction in blood pressure by 1 millimeter is fairly strong, but that the relationship wasn't as strong with regard to gaining muscle, right? So we basically know that progressive resistance training could impact our blood pressure. Usually that impact is on a smaller side, it's 3 to 6 millimeters or so, because this increased muscle mass really leads to improved glucose metabolism, insulin sensitivity, and that lowers blood pressure quite a bit. But the magnitude of that blood pressure lowering in study after study, including meta-analysis, is small, and the relationship between building muscle and reduction in blood pressure is less direct than what we see for fat loss. However, when we are in a situation where we execute the optimal strategy and we actually manage to lose fat but also gain muscle. And in all of our cardiometabolic programs at the Holistic Heart Centers, that's exactly what we're aiming to do, to help our patients lose visceral fat while maintaining or gaining muscle mass. We know that this is a much more effective strategy, and it actually amplifies the weight loss more than either strategy would achieve alone. In a study in 2009 that where individuals lost fat and they gained muscle because they combined aerobic and resistance training, they see up to 10 millimeter reduction in their systolic blood pressure. And you already know from listening to this episode that this is more than with either strategy alone. So there is this combination of losing fat and gaining muscle is critical because it resets the metabolism and optimizes the inflammation parameters and improves vascular tone and vascular resistance on multiple levels. So it engages the hormonal part of our bodies to influence our cardiovascular system. So this combination of fat loss with muscle gain not only improves the metabolic health, but it amplifies the benefits of achieving body composition, which is optimal. And that includes sizable blood pressure reduction. Hi to all professionals listening to us today. If you're thinking of launching a cardiometabolic or integrative cardiology program in your practice, we can help. At the Holistic Heart Centers, we help docs in practice to expand into hybrid or concierge services. Head out to the show notes and click on the application link. Your intro call is entirely free. Ready to schedule a practice review? Use code DOC10 for 10% off our Practice Power Hour 16 minutes coaching session. The link is in the show notes. Now, one of the things that crossed my mind, of course, in this era of Ozempics and Wegovys, there were some very interesting trials that have linked the usage of these medications to cardiovascular benefit. And one of those trials was a SELECT trial. It was published in November of 2023 in New England Journal of Medicine, and it would put medications such as GLP-1 inhibitors, not only on the map in terms of their impact on patients with diabetes, but the impact on patients with pre-existing cardiovascular disease who were overweight. So in the SELECT trial, patients were 45 years of age and older. They had pre-existing cardiovascular disease. They had body mass index of at least 27 or more, and they were randomized. So, 1-to-1 ratio, which means, they were equally divided into two groups. One group received this once weekly injection of Wegovy, which is semaglutide at 2.4 milligram. That's the dose. Another group received the placebo. And of course, as is always in cardiology trials, we care about primary cardiovascular endpoints, and those are death from cardiac issues or non-fatal myocardial infarction or non-fatal stroke. And so it's important for each new medication to be assessed for this, because in the past, some of the diabetic medications actually worsened cardiac mortality. And so when the study was looked at, it was a very large study. There were 17,000 or so patients, actually slightly more than that. So they were nearly equal. 8,800 received the medication and 8,800 received the placebo. And the follow-up was fairly extensive. It was 34 months, so almost 3 years. The mean duration of follow-up was almost 4 years. And so what they did noted is that there was a significant reduction in this combined cardiac event. So relatively speaking, 20% less of individuals in the medication group had actually achieved these cardiac endpoints. Now, I asked myself, then I looked at this study fairly extensively. This is not an episode about GLP-1s, but I looked specifically with an eye toward what was the body weight reduction. And again, it's average, and some individuals achieved less and some individuals achieved more. And how did that translate into the blood pressure reduction? And you could see here that we actually don't have the one-to-one relationship that I spoke about earlier, right? Earlier, I said that for usually in the guidelines based on the previous research, 1% of weight loss from your pre-existing body mass will lead approximately to 1 millimeter reduction in the systolic blood pressure, whatever your baseline is. Now, in the SELECT trial, and it was a very large trial, on average, patients lost about 10% of their baseline weight, right? So let's say if they were 200 pounds, 10% of that is 20 pounds. So from 200, they became 180. And with that, the blood pressure reduction was very modest. There was 3 to 4 millimeter reduction in systolic blood pressure, 1 millimeter reduction in the diastolic blood pressure. Now, there are a lot of newer medications in that class, and potentially different data may come to light. But that's as far as we know right now with these medications. They're fairly new. A better model to help us understand how much weight loss actually impacts blood pressure is actually a bariatric surgery model, because bariatric surgery has been a while for a long time. And usually bariatric surgery results in very profound weight loss. Most of the bariatric surgery patients are obese or morbidly obese, so they do lose a substantial amount of weight. And so based on the studies that are reported in the literature, we found what we expect, right? The more weight is lost, the greater is the reduction. And usually it's on the order of 10 to 20 millimeters of systolic blood pressure, 5 to 15 millimeters of diastolic blood pressure. What is very interesting about the bariatric surgery trials, and this is not what we had seen reported yet in the GLP-1 trials, but maybe it will be reported down the line when there's subgroup analyses, is that in the bariatric surgery trials, almost half of all patients experienced remission, which means they were able to come off blood pressure medications. They had controlled blood pressure without medications, and it was sustainable as long as they did not regain their weight. And again, these were very pivotal studies. One was done in Sweden, and it was called Swedish Obese Subjects, or SOS study. It was a long-term study. And this is where these mean reductions of 15 or so millimeters systolic, 9 or 10 or so diastolic come from. And these reductions after bariatric surgery were sustained over several years, with almost half of these patients achieving remission and coming off medications. Another trial was something called Stampede trial, which actually compared bariatric surgery to medical therapy. A little bit more modest blood pressure reduction, 12 millimeters systolic, 7 millimeter diastolic. And the trial also noted that 50% of those patients experienced remission. And so, of course, as always in medicine, we like to run meta-analyses where we put all these studies together and we try to say, well, what do larger numbers tell us? Let's try to do the statistics right and, kind of divide patients into representative groups and match them as much as we can so that we can derive conclusion based on the largest amount of investigations that we could. And so the meta-analyses on bariatric surgery do show they do bear these numbers. In patients who are obese and hypertensive, they achieve anywhere from 17 to 20 millimeters reduction in their systolic blood pressure and a little bit less blood pressure reduction in the diastolic blood pressure. Obviously, the more obese patients are and the more they lose, the more blood pressure impact there is seen, and there is this 50% or so opportunity for remission. So now let's go back to my patient, right? Because this is a patient who is working really hard through lifestyle modification, and I wanted to give this patient some measure based on what you just learned with me, about the rule of thumb calculation, and the role of total weight loss versus fat loss. So let's plug in those relationships. And I created an interesting little widget here. I call it blood pressure calculator. It's fairly basic. It's actually an Excel spreadsheet. And if you put a comment under the YouTube presentation or DM me through social media, I will send a link to you and you can play around with it on your own. So I'm going to go ahead and open it up and sort of just walk you through this, and let me make it a little bit bigger so that you don't have to, feel like you're going blind looking at this. So this is, I just took some very basic numbers, right? So remember how I said that for each 2.2 pounds gets you potentially a 1 millimeter of systolic blood pressure reduction. So this is what I'm trying to model here. This is this patient's rate, 160.9 pounds, and his current blood pressure on the average is 135 millimeters of mercury systolic. Obviously, we'd like it to be 120 or less, as you know, right? Because at 120, he will still technically be in the elevated blood pressure group, but at least he'll cross from hypertensive to elevated blood pressure. And so this initial spreadsheet uses the formula that 2.2 pounds of weight reduction will potentially drop blood pressure by 1 millimeters. So you would see that he'll need to lose 33 pounds if you lose that formula, and his new weight will be 127.9. Now, that could be a lot, especially for a person who isn't all that obese, because when we go and we look at his BMI isn't that bad. It's 25.2 actually. So he's not less than 25, but he's just about. And so here, what we are doing with our patients is that we actually do monitor body composition deliberately, because we know that it is the fat loss that actually drives the blood pressure reduction. So what can we tell this patient? Remember how in the just a few moments ago, I showed you research that not only identified that it's a percent reduction in weight, it's actually percent reduction in fat. So I'm assuming for the purposes of this calculation that this patient will lose fat, visceral fat, while preserving his muscle mass and potentially increasing his muscle mass. And so his fat mass is 34.2 and his fat percent is 21.3, and that's his current BMI. His initial blood pressure is 135 and I want to take him to 120. And so using the 1% fat mass reduction leads to, or could lead to, 1 millimeter reduction in systolic blood pressure. Using this calculation, you would see that he will need to lose 3.8 pounds of fat. Now, if he also happens to build muscle, he likely is going to see not just 1 millimeter reduction per 1% of fat loss, but maybe 1.2 or slightly more than that. We don't know. That remains to be seen. And so his new weight will become 157.1. His new fat mass will be 30.4. His new fat percent will be about 19. So it's not such a huge difference, right, between 21 and 19, but it's likely will be the impactful difference that will actually drive him out of that hypertensive range into the elevated blood pressure range. And hopefully in time, as he recovers his metabolic flexibility and builds muscle down into the normal blood pressure group. And you could see that his new BMI will be somewhat less than current BMI, 24.6. So this is the thought process, and let's just summarize it here so that I could leave you with some recommendations with regard to what you should be doing if you're considering a lifestyle strategy, specifically with weight reduction or weight loss as means of influencing your blood pressure. So first of all, know your BMI. If your BMI is in the overweight or obese range, your goal should be to bring it down into the normal range. How much weight should you lose? Well, you can use the rule of thumb. 2.2 pounds of weight loss could result in 1 millimeter of blood pressure lowering. The reason that I say could is that in all the trials that provided this number, patients did a variety of approaches. It wasn't just exercise, it was also diet and, behavioral therapies and so on and so forth. And in our cardiometabolic program, we actually follow patients with specific devices. And again, look in a gadget gallery next time so that you could see what those devices are. Now, if you do have access to a body composition scale, and you may be able to find a body composition scale at a local gym, sometimes vitamin shops have them. They have a body composition analyzer that you can just step on and get a result. A lot of the body composition scales are available directly to consumer. We use a specific company in our practice that helps us to achieve or monitor patients' body composition and links up to the practice dashboard so we actually know which direction a patient may be heading. But get access to the body composition scale or body composition analyzer and figure out what your fat mass is, what your muscle mass is, what your fat percent is. Now, another option, if you don't have access to body composition analyzer or scale, is actually a DEXA scan, because certain locations for DEXA scans will give you the body composition output. And then once you know the fat mass and especially the fat percent, that's really the game changer for you, because then you can calculate how much of that fat you need to lose in order to start achieving blood pressure target that you set for yourself. I already obviously programmed this into my blood pressure calculator as a spreadsheet, and I invite you to share your story. If you tried to lose weight and were successful and have seen an impact on the blood pressure, please let me know what it was. You can DM me or leave comments on YouTube. And if you tried it and you were not successful, please let me know what the roadblocks were. I will include a link in my response to this spreadsheet so that you can use it for yourself if that's what you like. You can certainly go ahead and make a calculation on your own calculator. You don't necessarily need a spreadsheet, but it just makes it a little bit more convenient. So I want to hear your story, and I want to learn from your journeys, and hopefully this has been impactful for you. So now you are prepared and you know what are the weight reduction goals that will actually impact your blood pressure. So I consider this rapid response successful because we actually accomplished something, learned something that we didn't know before. And until I see you next time in the Gadget Gallery. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Heart Centers. If you enjoyed the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticheartcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.